safe and efficacious in the elderly, an analysis using the NSQIP database. This is from Drs. Kim, Fleming, Gunzier, and Messing, and Sally Orn, I believe, and Monson at the University of Rochester. And I be presented by Dr. Kim.
Thank you very much. Good afternoon. Thank you for the opportunity to present. This is our disclosure slide. There was no external funding for this study. Laparoscopy has become a common approach for the treatment of acute appendicitis, but the safety and benefits of the laparoscopic approach have not been clearly established in the elderly population. Part of this is due to studies with small sample sizes or administrative data that don't rigorously follow up patients postoperatively. The aims of the current study were to compare laparoscopic and open approaches to appendectomy in the elderly population, with safety defined as postoperative complications and the benefits measured in terms of savings and length of surgical admission or length of inpatient stay. The study population were pulled from the National Surgical Quality Improvement Database from the years 2005 through 2008. There were elderly patients greater than or equal to the age of 65 years who had the diagnosis of acute appendicitis and who underwent open or laparoscopic appendectomy as defined by their CPT codes. One of the nice things about the NSQIP database is the number of perioperative, both preoperative and intraoperative factors that you can look at. So there was a comparison made between the two cohorts, the open and lap groups, with regard to these perioperative factors. And subsequently, univariate and multivariate analyses were performed, looking at three primary endpoints. We grouped together major complications and looked at any organ system failure events, DVT or PE, and organ space infection or peritoneal abscess, and a return to OR in this major complication group. The minor complication group included incisional infections defined as superficial to the fascia or urinary tract infections. Postoperative surgical stay, or the length of stay, was defined by the variable of days from operating room to surgical discharge. This slide shows some of the background characteristics of the two populations. One of the problems with NSQIP is that it's not randomized, so you end up taking what you get in the two different populations. The overall numbers, there were 3,335 total patients included in this, with almost exactly a third in the open group and two-thirds in the laparoscopic group. You can see there was a statistical difference with a number of, these are just representative factors from all of the different perioperative factors that we looked at, but the open group is older. There are more individuals who were transferred from some sort of chronic care facility prior to their admission. There were more individuals who had a dependent functional status, and overall, in terms of measures of how sick they were, the open group tended to be sicker. Unadjusted analysis showed that there were more complications in the open group as compared to the laparoscopic group. You can see that this was true both of major and minor complications with odd ratios over to the right-hand side there. We also separated out by looking at pre-discharge complications, both for major and minor, and that those favored the laparoscopic group in both cases. Given the differences at baseline between the two groups, multivariate analysis was performed. With exception of the comparison between the laparoscopic and open approach for major complications, you can see that all of the odds ratios were significant. So to interpret this slide a little bit, there was no association between surgical approach, lap versus open, and major complications. There was an association with minor complications, with laparoscopy showing a decreased rate of incisional infections and urinary tract infections. And below listed are other factors which came out significantly correlated with either of the two endpoints. In terms of the length of surgical stay, on unadjusted analysis, the mean length of stay favored laparoscopy with a difference of negative 2.3 days. And given the variability in this population, we also looked at the median, and there was also a significant difference of negative 2 days in favoring laparoscopy. Now, accounting for all of the different comorbidities and perioperative factors, laparoscopy on multivariate analysis still showed a benefit in terms of its decrease in length of stay. So after adjusted analysis, laparoscopy was still a benefit here. Listed below are the other factors that were associated with an increased length of stay. Interestingly, this would seem intuitive, but you can see the last two factors there, that pre-discharge minor complications end up with a pretty big increase in your length of stay there, 5.4 days, and major complications increase it even further at 8.23 days. So in summary, for an elderly population with acute appendicitis, the laparoscopic approach is safe. It's not associated with increase in major postoperative complications as compared to the open approach, and it is associated with fewer minor postoperative complications. And laparoscopy is efficacious. It results in a shorter length of postoperative stay, even given all of the other comorbidities in this age group. This concludes my presentation. Thank you very much.